Hello everyone, welcome to your lecture on diabetes. Let's get started. Now we mentioned in the previous lecture video that diabetes there are different types of diabetes, and what we're going to focus over here on are just type 1 and type 2 diabetes. Right? And if you can also go ahead and type your name in and go into the Genially and review it at your own pace as well. So type 1 diabetes, what is it? It's an autoimmune process in which insulin producing beta cells of the pancreas are destroyed, resulting in an absolute lack of insulin. For example, we mentioned in the previous lecture that with glucose regulation, when you have high levels of glucose in the blood, what happens? The pancreas release insulin, right? Now, in type 1 diabetics, the pancreas cannot release insulin because the beta cells of the pancreas that are responsible for the insulin are destroyed. So there's an absolute lack of insulin in the body, right? And it usually occurs in children, in young adults. Remember, the risk factor is less than 30 years of age, previously known as juvenile onset. It can occur in older adults as well. We call this late autoimmune diabetes of adulthood, LADA, right? So you might have an adult who finds out in their 30s or 40s that they have type 1 diabetes. It's very, very possible, right? There are 2 million Americans, including 304,000 children and adolescents with type 1 diabetes, and the number is growing. And approximately 8.7 million total diabetics were undiagnosed, right? 64,000 are diagnosed each year approximately, and the highest in this type 1 diabetes is the highest in people with European ancestry. What are the risk factors? Family history of autoimmune disorders, history of viruses such as mumps, rubella, or Coxsackie-B4, right? Then toxic chemical exposure can also cause type 1 diabetes. Early exposure to cow's milk can also cause type 1 diabetes. Now we're talking about type 1 diabetes here, right? Cytotoxins, substances that can kill living cells. So these things can basically toxic chemical exposure, early exposure to cow's milk, viruses, they can destroy your beta cells in your pancreas, and that's what ends up causing type 1 diabetes. Always remember, it's an autoimmune disorder. So the pathophysiology of type 1 is typically triggered, like we said, by autoimmune process, right? Your beta cells are destroyed. You can become hyperglycemic and ketosis prone very easy because you have no insulin, right? So if you eat something that has a lot of carbs, you have this circulating blood sugar in your body and hyperglycemia just there all the time. It can cause diabetic ketoacidosis. This can occur as a result of infection, under management of glucose. That's why it's extremely important in people who are diabetic to monitor for infections, because that can cause hyperglycemia in them. And for type 1s, when their blood sugars get too high, they're prone to DKA, diabetic ketoacidosis. It's a rapid progression. Total insulin deficiency occurs within a year of being diagnosed. They require lifelong insulin therapy. Surgical resection of the pancreas due to cancer or other diseases can also appear as type 1 diabetes, requiring lifelong insulin, right? But with type 1, they're insulin dependent, right? They can't take oral anti-diabetics, and we're going to talk about this when we talk about the medications. What are the signs and symptoms that we see in type 1 diabetics? The 3 Ps. These are the 3 Ps right here, right? The 3 Ps of diabetes. Polyuria, polydipsia, polyphagia. Polyuria is excessive amounts of urine. Polydipsia is excessive thirst. And polyphagia is excessive hunger. Then you also have fatigue, and initially you have weight loss in type 1 diabetics, so we have to be very careful with managing the nutrition because they can have excessive amounts of weight loss. Then you have glucosuria. in type 1 diabetics as well. What is glucosuria? Glucose being released in the urine. So you have high amounts of glucose in the urine. All of these are signs and symptoms of type 1 diabetes. Now, what is the medical management of diabetes? Medical management includes what? First, it's gonna get diagnosed, and then you're gonna treat the disease and the symptoms. That's how it is medically managed. So the first thing would be diagnosing it, right? How do we diagnose it? Just like any other disease process, first it has to be diagnosed before the treatment can start. Right? Like we mentioned that even when we talked about hypertension, right? It has to get diagnosed. It just doesn't get diagnosed the first time. The patient comes back again and then they still have it. So consistent hypertension, right? Then you get diagnosed with hypertension. Similar with this we have for diabetes, right? How do we diagnose it, right? With first is your hemoglobin A1C. So HbA1c, right? It measures the average amount of blood glucose concentrations in your body over a period of time, about 90 to 120 days. Why is that? Because your red blood cell, the life of your red blood cell is about 90 to 120 days. And so if you have consistently high levels of blood glucose in your blood, it's going to attach to that red blood cell. It binds to the red blood cell and it stays there for 90 to 120 days. And that's the reason why we check the HbA1c, every, 3 to 4 months. That gives us an average amount of blood glucose in their circulation. It can be done any time of the day. You don't require fasting. You don't have to tell the patient, okay, you have to fast for me to check your HbA1c. It can be done randomly anytime during the day. No fasting required. It's a good tool to monitor insulin therapy. For example, if the patient was diagnosed with diabetes and they were given insulin, and to monitor how well the patient has adhered to the, insulin and the treatment, that's a good way of monitoring their adherence, right? Because the patient might say, oh yeah, I've been taking my meds, I've been watching what I eat, I've been taking my insulin, but then when you check their HbA1c, it's really high. It shows that their glucose levels have actually been high over the past, 3 months. So it depends on the survival RBC of the red blood cells, as we mentioned, because it binds to the red blood cell. It should be less than 5.7% to be considered normal. So these are some numbers that you're going to have to remember, okay? These are extremely important for you to remember. So for diabetic people to be diagnosed with diabetes, their HbA1c has to be greater than or equal to 6.5% consistently, right? This is the key diagnosing factor of diabetes, right? What is prediabetes? 5.7 to 6.4. Less than 5.7 is normal. So remember these numbers. Less than 5.7 is normal, 6.5 or higher is diabetes, and prediabetes is 5.7 to 6.4. Okay, another way we can to diagnose diabetes, they do a fasting blood sugar, right? So for example, you're going to tell the patient you're going to have to not have any caloric intake. Except for water. Water does not have any calories in it. But, fasting blood glucose, is 8 hours of no eating. Okay? Then we call this the fasting plasma glucose. And it should be less than 126. This is another number you need to remember. Less than 126. Fasting blood sugar, less than 126. Extremely important for you to remember. So if the patient has a fasting blood sugar, plasma glucose of greater than 126, right, then they can be diagnosed with diabetes, right? And what is it for pre-diabetics? If your fasting blood sugar after 8 hours of fasting is between 100 to 125, then you could be pre-diabetic. So, okay. So what about another one? This is another, test we do to check for diabetes, right? Now remember, we're trying to diagnose diabetes here, which the doctor orders, in order for the patient to get diagnosed. We did the HbA1c, we did the fasting blood sugar. Now the oral glucose tolerance test, it's also called a 2-hour postprandial test as well. So basically, the patient consumes a beverage containing a glucose load of 75 grams. After they fast 8 to 12 hours, then they drink a beverage that has about 75 grams of sugar in it. Then 1 to 2 hours later, normally it's 2 hours, a sample blood sugar is taken from them. And then if that blood sugar level is greater than or equal to 200, then that patient will get diagnosed with diabetes. Normal is less than 200. Usually you'll notice this in pregnancy. It's done, I think around, if I remember well, it's usually done around like 20 weeks or so. They do a oral glucose tolerance test. Positive results if the patient had, for example, a blood sugar of 200, or more after that 2 hours, then, they confirm those results in a subsequent visit. Then the patient comes back and they do it again, and that's when it's confirmed. So the fourth thing, another way, of checking the random blood glucose level is just doing a finger stick blood glucose just randomly, right? You don't calculate, okay, is it before meals, after meals, fasting, anything. You just randomly poke that person and check their blood sugar. And if it's greater than, 200 milligrams over a deciliter, and the patient has the classic symptoms of hyperglycemia. What were those? Your 3 Ps, right? Those are the classic symptoms of hyperglycemia. Then it indicates diabetes mellitus. So these are the 4 different labs we do to diagnose diabetes. Over here, I have written right here, there's a chart. Please remember these numbers. And if you notice, there are only a few numbers that you need to remember. Diabetes 126, right? 200, 6.5, 200 again. So please remember these numbers. It's extremely important for you to know these. Okay, so this is how we, check for diabetes in patients, how patients are diagnosed with diabetes, So let's test your knowledge. The nurse monitors which lab results to assess the patient's average blood glucose concentration over the last 6 to 12 weeks, or say 90 to 120 days. Okay, let's see, did you guess B? B is the answer. Remember we said hemoglobin A1C, HbA1c is what we check to give us an average over the past 90 to 120 days. Okay, this is type 1 diabetes for you. Now that's how we diagnose it. What about treatment? Treating type 1 diabetes. So we have pharmacological interventions, nutrition management, a lot of education. Diabetes requires a lot of education. Now we're talking about type 1 diabetes. Keep that in mind. And then detection, prevention, self-management are also very important. So let's look at pharmacological management. So glycemic control. These are 3 methods of assessing glycemic control. What is glycemic control? Keeping your glucose under control, managing your glucose, right? Self-monitoring of blood glucose. What is that? When the patient basically has the glucometer at home and they check their blood sugars and they monitor their blood sugars and keep a log of it and report it to the provider. This is self-monitoring of blood glucose, right? The frequency, how often do they need to check their blood sugar? That depends on if they're taking insulin, how many hypoglycemic reactions they've had, the level of their glycemic control, how much they eat, all those things. So how many times they check their blood sugar is going to be prescribed by the doctor, and it depends on all of these things. Usually a patient with type 1 diabetes should check before meals and at bedtime. So that's 4 times a day. Remember that, 4 times a day, before every meal and at bedtime. Okay, normal value is usually between 70 to 120. That's what's considered normal for a diabetic patient. Anything less than 70 is, considered hypoglycemia. Anything above 120 is considered hyperglycemia. So this is what we need to remember. This is another number. Now, this number applies to diabetic patients. Okay, so another way of, maintaining glycemic control is what we call continuous glucose monitoring. This can be with or without an insulin pump. Now, some people have a sensor attached to a transmitter that's inserted subcutaneously in the abdomen or the back or arm. It's connected to a wireless monitoring device that displays their blood glucose levels in real time. So it's an excellent way of people who are type 1 especially, or type 2, to monitor their blood glucose levels, right? They have apps that they can get on their phone that tell them exactly what their blood sugars are. And some people have insulin pumps attached, along with that. So if the blood glucose is high, then they can actually get the insulin as well. Some people don't have the insulin pump. They manually give themselves the insulin based on their blood sugars. But that monitors their blood sugars continuously. Right? Sensors are replaced every 7 to 14 days that are subcutaneously placed. They're replaced every 7 to 14 days. The data is downloaded and analyzed. It can be worn up to 90 days. It's mostly used in type 1 diabetics because, they're younger people, they're in college, they're in school, and they might, it's a better way of managing their blood sugars. The normal value, once again, is usually between 70 to 120 for a diabetic patient. Now, monitoring of HbA1c is another way of, watching for glycemic control, right? And you measure the glucose control over the past 3 to 4 months. Normal values 4 to 6% for diabetic people. You want to put the target for diabetic people is less than 7%. That's where their target goal is. Less than 7% is the best, right? Okay, so that is talking about glycemic control. Now, we mentioned for type 1 diabetics, insulin therapy is the only treatment. We don't use oral anti-diabetics for them. They don't work because they don't have the beta cells. So there's an absolute lack of insulin in the body. So you have to give them exogenous insulin. Basically means from outside, right? They have no endogenous insulin. Nothing inside them. So we have to give them insulin. So treatment plans, they usually mimic the response of healthy pancreas to blood glucose levels during the course of a day. For example, for an average person who has, say, no, diabetes, they're not diabetic, normal, healthy, functioning adult, right? Throughout the day, what happens? Right? We say, for example, you wake up and you just had a coffee. You didn't, then you had, say, for example, you had coffee and you had a big breakfast, pancakes, waffles, loaded with syrup, huge one, whipped cream, strawberries, whatever you want to add to it, right? Say you had a big breakfast, and so what happens to the glucose in your blood? It increases, right? And so if the blood glucose increases, what's going to happen? Your pancreas are going to release insulin. We mentioned this when we talked about glucose regulation, right? Pancreas will release insulin. The insulin is then transported to the cells, to the liver, and to muscle and adipose tissues, right? And so it comes out of your blood. And so then your blood sugar levels, the glucose levels in your blood are, decreased. And now, say, for example, you go to work, you're busy all day, you're in school, you just don't have a chance to, eat. So you haven't eaten all day. So now what happens to the blood glucose level in your body? Your levels are going to drop, right? You're going to have low blood sugars. So now what happens? In an average person, the liver, releases the stored glycogen as glucagon into the blood. And so now that glucagon increases the blood sugar levels in your blood, maintains it so your brain can get the glucose that it needs to live in your body, right? And so then, say, for example, later on that day, you go and eat a big meal again, and then the same process happens again. Say you decided, okay, I'm going to go for a 4-hour walk before I go to bed, and now your blood glucose levels, they drop, you're burning out that sugar, right? Your blood glucose level drop, and so your body the liver will then release the glycogen. So this is happening throughout the day, right? This is an average in the way your glucose regulation in a healthy adult works, right? And a healthy person works, right? So now for people who are type 1 diabetic who have no beta cells to produce any insulin, what's going to happen when they eat a big meal? All right. Or, they don't have any insulin. And so insulin therapy, when the doctors prescribe insulin for a patient, a treatment for a patient, the best one is the one that mimics that response of healthy pancreas. Like the person, remember we talked about the average healthy person, right? And so the best insulin therapy is one that mimics that the closest, right? This is called your basal or your minimum level of insulin throughout the day and at meal times. And so a combination of long acting or intermediate acting can be used that can provide that basal insulin. See if you notice here that line, you have peaks when you have that big breakfast or a big lunch, big dinner, and then, or when you're not eating anything. So you want the insulin therapy to mimic this exactly at least very close to the way an average healthy adult does, right? The amount of insulin that the patient takes depends on their blood glucose rating, right? So if their blood glucose is, however they do it, whether they're self-monitoring their blood glucose, whether they have continuous glucose monitoring, or they're using a sliding scale. A sliding scale is a scale basically based on, for example, if the patient's blood sugar is between, 120 to 180, then give them 2 units. If it's, 180 and 250, then give them 3 units. So usually there are different types of scales. You have like low, medium, and high, moderate or intense scales. And depending on how much their blood sugar is, they get insulin. Okay. So this over here, as you can see, is basically shows, the effects of insulin, the different types of insulin. When you're reviewing the genealogy for type 1 and type 2 diabetes, please take a look at this for more detailed, information. Okay, what are the different types of insulins? They're different preparations. Please do not confuse the insulin. So you have to know which one is which. This is extremely, extremely important because a lot of people die from being given the wrong type of insulin. Too much of, for example, the rapid insulin that puts them into severe hypoglycemia and causes death. So rapid acting insulin, it's a rapid effect. It's a shorter duration. The patient should eat within 15 minutes. Remember that. You cannot give rapid acting insulin unless the patient is going to eat within 15 minutes. They have to eat. Okay. Short acting insulins. They're regular insulins. You'll see a R on the bottle marked, showing that it's regular insulin. It's a clear solution, just like the rapid acting one, and it's given 15 minutes also before a meal. Now, when you hear insulin given by IV, that is only for regular insulin. No other insulin can be given by IV. Only regular insulin can be given by IV. Where I'm talking about intravenously, like through an IV pump. Then you have intermediate acting insulins. It's called NPH insulin, the neutral protamine hagedorn, right? It's similar in course and time of course of action. Normally it appears a little milky or cloudy. It's not you don't necessarily have to take it right before a meal, right? But you need to know the peak and onset of it because when it's going to peak, that's when you want to make sure that the patient is eating. Okay, because that's when their blood sugars are going to drop the lowest. Okay, long-acting basal insulin. So this is peakless. It maintains a regular amount of insulin throughout the day, right? It's absorbed very slowly over 24 hours and is given once a day. And some people it's given twice a day in the morning and at night, depending on their glycemic control, right? And it's not mixed with any other insulin. We don't want to mix this with any other insulin. So when administering insulin, it's extremely important to read the label carefully to be sure that you're using the correct type of insulin and dose of insulin. That's extremely important for us to remember. Now, when you review the genially, please look at this chart. This is an extremely important chart that you absolutely should know, right? You have your rapid acting insulin, that's Lispro insulin. Onset is 15 to 30 minutes, right? And the peak is 30 to 90 minutes, and then you have duration. It lasts for less than 5 hours, 3 to 4 hours for some of them. Now, this is used for rapid reduction of blood glucose to treat with postprandial, after meal, postprandial hyperglycemia to prevent nocturnal hypoglycemia. So basically, that's when the patient is eating. Their blood sugar levels are going to go high, so we give them insulin before they eat. So short-acting insulin is the regular insulin, right? Its onset is 30 to 60 minutes. So you want to make sure that the patient eats, within 15 minutes of their, usually given 15 minutes before the meal. You always want to make sure that the patient eats, right? It can be taken alone or in combination with a long-acting insulin. For example, a patient might be given short-acting insulin, regular insulin, say 3 times a day before meals, 15 minutes before the meal, right? And then they could be given a long-acting basal insulin, we talked about, right, at night before they go to bed, or once a day in the morning. So just depends on the patient's glycemic control, how well their diabetes is managed. Then you have intermediate acting insulin. That's the NPH insulin we mentioned. The onset is 1 to 1.5 hours. So if the patient is going to take it, we need to make sure that they're eating 1 to 1.5 hours. The peak is 4 to 12 hours, and it lasts up to 24 hours, the NPH insulin. Food should be taken around the time of onset and peak. Then we have the long-acting insulin. That's the glargine. There are different names for it, Lantus, glargine, but this is the generic name for it, glargine detamir. And the onset is 3 to 6 hours. It's, takes action at 3 to 6 hours, and it's continuous, no peak, because remember, it's your basal insulin, the minimum required to survive through the day, all right, without getting hyperglycemia. Duration is 24 hours. It's used for the basal dose. Then you have rapid acting inhalation powder. It's a new thing, Afrezza. Its onset is less than 15 minutes. The peak is approximately 15 minutes, administered at the beginning of a meal, also with a meal, because remember, it's rapid acting. So rapid acting, short acting, 15 minutes within a meal, okay? And pH is intermediate acting, just make sure that the food is taken around the onset and the peak. Long acting is peakless. It's given to just maintain their basic insulin levels. Okay, so insulin treatment plans. We mentioned there are other treatment plans as well. You have this, insulin pumps. They provide rapid acting insulin. Remember, we mentioned continuous glucose monitoring. People can have pumps, and it checks their blood sugars, and then based on their blood sugars, the insulin pump delivers that amount of insulin into their body subcutaneously. Now, a patient is still responsible for carb counting though, right? The pump doesn't count those things for you. You have to count your carbs. And we're going to talk more about carb counting when we get to the nutrition part. Then you have Lantus, which is your long-acting insulin, and then sometimes the insulin comes in these insulin pens. Now, an alternative plan for treatment of patients, right, with diabetes. Like, remember, we said that patients, the average health literacy level is a 6th grade level. Now, patients who are going home with the diagnosis of diabetes, especially when they're new to it, it takes them time to get used to it, to manage their carbs, to manage, their blood sugars, to manage, it's called glycemic control. And okay, taking the insulin, it's something new for them, right? Another alternative treatment plan, which isn't the most ideal, is basically for patients who choose not to manage multiple daily dose, glucose evaluations. These are patients who okay, I don't want to check my blood sugar all throughout the day, 4 times a day, and then give myself the insulin. I just don't have time for that, right? Then they have these different, combination medications that they can take, right? It does not provide tight glycemic control, obviously, because you're not checking your blood sugar and then giving yourself the insulin like that, right? You're just taking some insulin every day. It's less complicated, and usually a mixture of rapid acting and intermediate acting insulin. And if you see here, these are some examples of the different types. Okay, then we talked about treatment plans, insulin regimens. We mentioned, depending on the person, how their glycemic control, depending on what their blood sugars are like, that's what's going to determine the kind of insulin treatment they're going to get. Conventional is 1 or more injections of short or intermediate acting a day. It's simplified to avoid complications due to non-adherence. Patients should not vary meal patterns or activities. They need to have consistent meals and activities. It's used for terminally ill, older, frail patients, those unwilling to self-manage. That's your conventional, insulin therapy. So now intensive insulin therapy is a lot more complex to control blood sugar glucose levels, but it's safe and it's more accurate. It maintains a tight glycemic control. It allows, it reduces the risk of complications, the tight blood control of blood glucose, 3 to 4 injections per day, but then you have increased risk of hypoglycemia because they're taking a lot of insulin. So patients need to manage, their blood sugars. It's used for patients with chronic kidney disease or kidney transplant, right? It's not used for patients with nervous system disorders. It's recurring severe hypoglycemia, irreversible diabetic complications, for example, blindness and end-stage kidney disease, ESKD, severe, CVA or cardiovascular disease, ineffective self-care skills. It's not for them because they're going to have severe hypoglycemia, which, like we mentioned, can cause a lot of complications. What are the complications of insulin therapy? Remember, we mentioned, any disease process, when you take a medication, it can create the opposite effect, right? If you take an antihypertensive, it can cause extremely low blood pressure, right? Same thing with insulin. If you're taking insulin, it can cause hypoglycemia. What is hypoglycemia? It's a blood glucose level of less than 70. It's acute or life-threatening, right? Because remember, it has devastating effects on your central nervous system because your central nervous system solely relies on glucose for energy. So it needs a constant supply to maintain that function to avoid cell death. Patient at risk are the patients with decreased nutritional intake. All right, they're not taking a lot, going through starvation, things like that. That's severe hypoglycemia. Increased metabolism of glucose for exercise, so people who exercise a lot and they're not eating enough to maintain themselves. Alcohol consumption, it blunts the release of glucose from the liver. So when your blood sugars are low, alcohol consumption can cause your liver not to release that stored glycogen as glucagon. What are the clinical manifestations? When blood glucose levels drop below normal levels, the body attempts to raise the glucose through the stimulation of the sympathetic nervous system and the release of hormones such as epinephrine, norepinephrine, glucagon. So what happens when you get a dose of epinephrine from your body? Everything goes crazy, right? You have headaches, you have nausea, sweating, tremors, lethargy, hunger, confusion, slurred speech, tingling around the mouth, anxiety and nightmares. Please remember these symptoms, extremely important. Please remember those. How do we manage hypoglycemia, right? If the patient is conscious and able to swallow, right, we administer 15 to 20 grams for a conscious patient, any form of rapidly absorbed carbohydrates. For example, juice, soda, honey, jelly, bread, or crackers. Even crackers will give them a quick, 15 to 20 grams of carbohydrates. You want to measure within 15 minutes. If the blood sugar is still low, repeat that. So once it's normal, make sure that they eat a snack to prevent another episode of it, right? So this is for a conscious patient that's able to swallow, right? You don't want to shove a cracker into the mouth of an unconscious patient, right? That's only for the conscious patient. Patient unable to swallow, and they have IV access. If they have IV access, then they're given IV dextrose. We call it D50, 25 to 50 milliliters of 50% dextrose, call it D50, and is administered through the IV. If they don't have IV access, and the patient is not able to swallow, we're talking about a patient not able to swallow, right? With IV access, give them D50. If they don't have IV access or, and not able to orally take in carbohydrates, then you give them a 1 milligram of intramuscular glucagon injection, right? Looks like an EpiPen, it's just glucagon. You inject that in them. This glucagon mobilizes the glucose release from the stores in the liver. Now, it's important to remember when a patient is a diabetic and they're, having a hypoglycemic event, they might not remember to do this right at home. Obviously, they don't have IV access. But even to give the glucagon injection, they might not be, because remember what happens, when you don't have enough glucose, it affects your central nervous system. So you're going to have that confusion, the lethargy, and all those things. You're having all those symptoms, right? And so you need a family member to do it for them. So we have to educate the family on how to do it. So we instruct them to inject the injection the way they're supposed to do it, show them, okay, hey, you got to inject that in the muscle. As soon as you inject it, you need to call for emergency help, call 911, turn the patient to the side, because once, the patient gets injected with, the glucagon, its side effect is nausea and vomiting. So we want to make sure that they turn them to the side so they don't vomit and aspirate on their own vomit. So it's available in injection or nasal spray. Every facility, and one thing we need to remember is that depending on which hospital you work in, every facility has its hypoglycemia protocols. Just like we talked about fluid and electrolytes, right? The electrolyte protocols, we have hypoglycemia protocols at every facility. Okay, so that is hypoglycemia, which is a complication of insulin therapy. Then we have other ones here. This is a dawn phenomenon, relatively normal blood glucose until approximately about 3 a.m. The blood glucose levels begin to rise. Usually happens in type 1 diabetics. It's due to increase in growth hormone secretion at that time. It creates a greater need for insulin in the morning. It's treated by changing the time of injection to the evening, intermediate acting insulin from dinner time to bedtime. Okay, then we have insulin waning. Insulin waning is progressive increase in blood glucose from bedtime to morning, right? Frequently seen in the evening, NPH dose is given before dinner. It's prevented by moving the evening dose of NPH to bedtime. So by giving it to bedtime, we can make sure that the blood glucose throughout the night is not so high. Right? Same with the dawn phenomenon we notice. The Somogyi effect is normal or elevated blood glucose at bedtime, early morning hypoglycemia. So they wake up with extremely low blood glucose and a subsequent increased blood glucose caused by the production of counter-regulatory hormones. So what happens when they have hypoglycemia early in the morning, their body is trying to increase that blood sugar. And so it's, we don't want to make sure that, their blood sugars don't drop too low. Okay, then other complications of insulin can be just allergic reactions, systemic allergic reactions, insulin lipodystrophy. That is a localized reaction in the form of lipotrophy, basically occurring at the site of insulin injections. They develop, a reaction that's called insulin lipodystrophy. And you could have insulin resistance, right? Remember we talked about coffee and the liver? Same way, right? When you have been constantly giving insulin, patients might become resistant to insulin. And when that happens, they're given stronger concentrations. We call the U500, right? But now they need more and more and more insulin. And so when we're giving insulin, we need to make sure that we're giving the patient the right concentration. You don't want to give them the U500 concentration. Their concentration, usually the normal one is U100. Okay, so that was insulin therapy. So this is type 1 diabetic. We talked about pharmacological intervention, maintaining blood sugars, insulin. Nutritional management includes weight loss. We want to make sure that the patient loses weight. Weight loss of 5 to 10%. A total weight may significantly improve blood glucose levels. It helps eliminate medication to control diabetes. You want to teach them to take consistent meals. Don't skip meals. If you're going to eat breakfast, lunch, dinner, eat breakfast, lunch, dinner, right? We want them to, decrease overall caloric intake, not skip meals. Please remember that. We do not want to tell patients to skip meals. Take consistent meals throughout the day, just decrease the overall caloric intake, meaning eat smaller meals, right? Make sure they take snacks in between, and we need to teach them what kind of snacks to take so that way they can prevent hypoglycemia and hyperglycemia. Meal planning is extremely important, for patients, lifestyle and cultural eating patterns, patients' literacy level, patients' psychological status. Patients who are depressed are prone to eating a lot more. Okay, then caloric requirements. What are the caloric requirements for diabetic people? It's based on age, gender, height, and weight, right? We want a 1 to 2 pound weight loss can cause a reduction of 500. That means reducing 500 to 1,000 calories a day to get the 2 pound weight loss, right? Type 1 diabetics may more than likely in the beginning may be underweight, right? At onset, provide a higher calorie diet to regain the lost weight due to severe hyperglycemia. What is the daily intake? Carbohydrate should, and please remember this, 45 to 50%. Proteins, 15 to 20%. Fats, less than 30. Fiber, at least 28 grams of fiber daily. So remember those numbers, 45 to 50 for carbs, 15 to 20 for proteins, and less than 30 for fats. And we want to encourage fiber, at least 28 grams. Those are the caloric requirements. Meal planning. There are different ways that diabetics can meal plan. There are different, that nowadays we have a lot of apps that can help them, but diabetic education is extremely important. We have exchange lists where they have like 6 main categories, and these meals can be exchanged. Okay, today they might decide to eat the bread and starch, and then they can eat this much meat if they eat that. So it's like an exchange list. Another one is nutritional labels, being able to read nutritional labels, and carb counting. We're going to practice carb counting also in Skills Lab. We want to teach patients how to count their carbs, because sometimes the doctor might say, okay, you're going to take 1 unit of insulin for every 15 grams of carbs that you're eating, right? It's actually less complicated, so we need to teach them how to count those carbs, using nutritional labels, the labels on the food items, making healthy food choices, right? And teaching them, what choices are best for them. Foods that have high glycemic index, that means a lot of, carbs in them. Food that have low glycemic index or medium glycemic index. We want to teach patients, and we're going to practice this also in Skills Lab. We want to teach patients how to make the right choices. Then you have the My Plate Food Guide. It's food categorized in 5 major groups. You have grains, vegetables, fruits, dairy, and proteins, fats and oils. We recommended is high in complex carbohydrates and fiber, low in fat. That's what we, want to encourage diabetic people to eat. Now, some people might want to still take the alcoholic beverages. They can be added to the diet, but you have to plan those in, because if they're taking alcohol, then we need to teach them, okay, hey, if you're taking this, then these are the things that you're going to have to cut down on, right? So it's extremely, extremely important. Providing them the nutrition information is also important. Please read over this nutritional management document that I uploaded in your Canvas course. Please read over this. This has a lot of important information, and we're going to go over this in class as well, but please read over this before you come to class. This gives you more information on exchange lists, nutrition labels, and carb counting, and how to read food labels. What is glycemic index? It has links over here for you to read. Please go over this before you come to class. Okay, so that is nutritional management for diabetes. So basically, it consists of counseling, education, ongoing monitoring, interdisciplinary team, or consult with a registered dietitian. According to the American Diabetic Association, the goals are blood glucose levels in normal range or as close to normal, lipid profile normal, reduced cholesterol, reduced blood pressure levels, right, at normal levels, prevent and slow the rate of development of complications, address individual nutrition needs, and maintain the pleasure of eating by only limiting food choices when indicated by scientific evidence. We don't want to scare them off to the point where they don't want to eat, because that can cause hypoglycemia as well. So these are the goals of diabetic maintenance according to the American Diabetic Association. Now, what education do we want to provide patients with diabetes? We want to type 1 diabetes, signs and symptoms of hypo and hyperglycemia, how to administer insulin, right? The methods and the techniques, medication education, regular blood glucose monitoring, monitor for complications. We talked about the complications of insulin, medical nutrition therapy, their medications, their nutrition. We need to provide them with that information. Healthy lifestyle, nutrition, diet, and exercise. Foot care is extremely important to teach diabetic patients. We need to teach them to wash their feet every day with warm water and soap, right? Avoid soaking the foot because it can cause, skin damage. Keep the foot clean and dry. Dry doesn't mean like, scaly dry, but just dry, not wet and moisture. We don't want them, just like the reason why we don't want them soaking it. Well-fitting shoes. Well-fitting, and it's recommended to wear leather shoes, but well-fitting leather shoes. Avoid being barefoot. Wear clean socks. Your socks should always be clean. Nails should be cut and filed, right, regularly. They might need to consult a podiatrist for removal of corn and callus removal. We need to always teach them that illness and stress produces glucose, and this can raise their blood glucose. So when they're ill or they're stressed, they need to continue to take their insulin, notify the provider, because the insulin might get adjusted because the blood glucose goes up. We need to teach them about sick day rules, the days that they're feeling sick, right? We need to teach them to take the insulin to control the blood glucose, because some people might think, oh, I'm sick, so I don't need to take my insulin right now. No, that's when they really need to take it, right? They need to monitor the blood glucose a lot more frequently when they're sick. They need to watch for signs and symptoms of hyperglycemia. They need to contact the provider immediately if there is a suspected infection. Infections are very dangerous for people who have diabetes. Okay, and that is type 1 diabetes for you. And that was client education, blood glucose monitoring. As we mentioned, you have the different types. You have self-monitoring of blood glucose, right? Continuous glucose monitoring, and the monitoring the HbA1c. We mentioned this earlier. Then let's talk about complications. These apply both to type 1 and type 2 diabetes. What are the complications? They're classified as macrovascular or microvascular. Macrovascular complications involve damage to the large arteries that supply the heart and the brain. Example, chest pain, angina are all examples of macrovascular, complications. Microvascular complications are long-term damage to small blood vessels like capillaries, and this can affect multiple organs, because remember we said nutrients are, exchanged at the capillary level. So this can cause, damage to the organs. Example, diabetic neuropathy. So what are other complications of diabetes? You have integumentary, skin infections, wounds that don't heal. That's a huge sign of diabetes, right? Then you have acanthosis. That's thickened, velvety, and dark patches of skin that you'll notice on people who have diabetes, Then you have, with oral cavity, you have periodontal disease. You have, candidiasis. We talked about the yeast infections, right, in the mouth. You can have, those are very common in people with type 1 and type 2 diabetics. Eyes, they can have cataracts, retinopathy, the cardiopulmonary system, angina, shortness of breath, hypertension, periphery, poor peripheral perfusion, as evidenced by coolness at the extremities. The extremities feel cold. They have hairless skin, shininess and thinness of the skin, weak absent pulses, ulceration on the extremities. You have venous and arterial ulcers that develop in your lower extremities. Pallor, you see thick nails with ridges. With kidneys, you'll notice edema in the face, hands, and the feet. Especially with kidney damage, you'll notice them in the feet. right? UTIs, recurrent UTIs are common in people with diabetic. Renal failure is something that can happen with, as a complication in diabetes as well. What are the symptoms of renal failure? You see anorexia, edema, nausea, fatigue, difficulty concentrating. Then you have diabetic nephropathy. Basically, nephropathy is a, condition of the kidneys. Neuromuscular wise, you have diabetic neuropathy, numbness and tingling and pain and burning sensation in your fingers and toes and stuff. Diabetic people is very common in people with uncontrolled diabetes is diabetic neuropathy. Remember that, numbness, tingling, pain, and burning. GI disturbances, you have nighttime diarrhea, gastroparesis. Then reproductive, in men you have impotence. In women they might have vaginal dryness, frequent vaginal infections like yeast infections, menstrual irregularities. The high blood glucose levels causes, yeast infections, whether it's in the mouth or in vaginal yeast infections. Then you have psychosocial issues, right? Depression, it contributes to the lack of adherence, right? They're depressed. They're like, oh, why should I even do all of this? Kind of feeling, right? Then they have increased risk of developing anorexia nervosa or bulimia nervosa, especially in type 1 diabetic, females. Anorexia nervosa and bulimia nervosa are common. Okay. So this over here is a list of complication of diabetes. It is uploaded in your Canvas page. Please take a look at it. Okay, and then finally DKA. What is DKA? We mentioned this before, diabetic ketoacidosis. It's a metabolic derangement, most commonly occurs in type 1 diabetics and results from the deficiency of insulin, because remember they have no insulin, right? So they have highly acidic ketone bodies are formed and it results in metabolic acidosis. You'll notice this can happen in blood glucose levels of greater than 200 and consistent blood glucose levels of greater than 250. So that is type 1 diabetes. This over here is just, basic description of what we just discussed, treating diabetes. You have pharmacological interventions, nutrition management, education, detection, prevention, and self-management. These are extremely important. So let's test our knowledge. The charge nurse is reviewing orders for a newly admitted patient with type 1 diabetes. It is a priority for the charge nurse to follow up with the provider about which order. Please make a note of this and I will provide you with the answers to all your test your knowledge questions in class. Okay, this is another question right here. The nurse is providing care for a patient newly diagnosed with type 1 diabetes. Which lifestyle modification need to be included in the plan of care? Go ahead and take a picture of this question, or if you're viewing the Genially, please, note this and we'll discuss these together in class. Okay, so that was type 1 diabetes, right? Type 2 diabetes is very similar, okay? And a lot of the information is going to be similar, so I'm only going to go over information that is different from type 1 diabetes, just so you can note it. So let's talk about the epidemiology. It affects 11.3% of the population, accounts for 90 to 95% of all the cases. Most common in adults than juveniles, increased due to the increased level of obesity and inactivity in people. In children, the onset is 10 to 19 years of age if they have type 2, right? Because what does it mean? If they have type 2 diabetes, they have some insulin production. Just because they're young doesn't mean their diabetes is type 1, right? What differentiates type 1 and type 2 is that type 1 is absolute lack of insulin. Type 1 is absolute lack of insulin, and type 2, is when they don't have enough insulin. Okay, it's most prevalent among American Indians, Alaskan Natives, non-Hispanic Blacks, and Hispanics overall. And type 1 was most common in people with European descent. Okay, what are the risk factors? Modifiable. You have modifiable and non-modifiable risk factors, right? BMI greater than 26, physical inactivity, right? High density, in low HDLs, higher triglyceride levels, high cholesterol levels in general, then metabolic syndrome. What is metabolic syndrome? Metabolic syndrome is abdominal or central obesity, a waist circumference of greater than 40 inches for men and greater than 35 for women. And all of these have to be present. All these 5 conditions have to be present for it to be metabolic syndrome. Then you have increased triglycerides greater than 150, decreased high density lipoproteins in males and less than, in males and females, less than 40 in males and less than 50 in females, hypertension greater than or equal to 130/85, fasting blood glucose greater than 100. So all of these together are known as metabolic syndrome. So these are modifiable risk factors. These are things that people can modify, right, to improve the glycemic control. These are things they can change. Non-modifiable are what? First-degree relatives, right? Then you have members of high-risk ethnic populations. You have patients who delivered a baby weighing greater than 9 pounds or who were diagnosed with gestational diabetes. Hypertension of greater than 140/90, or on therapy for hypertension. That's with therapy for hypertension. Polycystic ovary syndrome, HbA1c greater than or equal to 5.7% on previous testing. History of cardiovascular disease. These are all non-modifiable risk factors for diabetes. Okay, so there's a question here. The nurse is screening patients for the risk of developing type 2 diabetes mellitus. The nurse should consider which patients at risk. Select all that apply. Please go ahead and take a note of this question or take a snapshot, and we will discuss the answers in class. So let's talk about the pathophysiology of type 2. It's defects of the cell membrane that prevent the normal action of insulin. They're not producing enough insulin. Even though the insulin is present, the cell is resisting its effect. For example, the insulin is there, your pancreas releases the insulin, but the cells are resisting that insulin. So you have increased resistance, not producing enough insulin or resistance to the insulin. That means that it requires increased level of insulin in order to drive the glucose into the cells. Over the time, the pancreas cannot keep up with the increased demand for the insulin, and the beta cell failure appears and progresses. In later stages of type 2, insulin production declines significantly, so that approximately 30% of the patients with type 2 eventually require exogenous insulin delivery to maintain normal blood glucose levels. It's a slower onset than type 1. Now, the thing is that, a lot of diabetic people, if they maintain change their lifestyle, maintain their glycemic control, a good tight glycemic control, they can actually just live off oral diabetics for a long time, right? Very long time. They might not ever need insulin, but some of them might need insulin a lot faster if they don't maintain their lifestyle. So signs and symptoms of type 2. The 3 P's, they're common in both, type 1 and type 2. Fatigue is also there in type 1. Poor wound healing, right? Cardiovascular disease, visual disturbances, renal insufficiency, recurring infection, example, yeast infections in women. So why are these listed here as, signs and symptoms? Because remember, type 2 occurs later in life. Sometimes people don't realize they have diabetes, right? Something like poor wound healing happens, and then they're like, why isn't my wound healing? And then their blood glucose gets checked, right? Oh, you're type 2 diabetic, right? So it's already progressed to that level. They have cardiovascular disease, or they have visual disturbances. For example, one day they're like, oh my God, why do I have blurred vision? And then they find out they're type 2 diabetics. So that's the reason why they're listed here as signs and symptoms, right? Recurrent yeast infections in women, that also, signifies, maybe it's an indication of type 2 diabetes. So the classic symptoms are the 3Ps and fatigue. Okay, we have 2 questions here. Please take a note. The nurse is screening patients for the risk of type 2 diabetes. The nurse should consider which patients at risk. Oops, I think that's a repetitive question here. Then we have this question. The nurse recognizes which of the following statements as correct in relation to the pathophysiology of type 2 diabetes mellitus. Select all that apply. Go ahead and take a screenshot of this or note the answers, and we will discuss these in class. Okay, medical management of type 1. Same thing as type 2. First gets diagnosed, then it gets treated, and we treat the disease and the symptoms. So the diagnosis, once again, is exactly the same as type 1. We check the HbA1c, and it has to be what is the number that we talked about, right? Let's look over here. These are the things that they're gonna check. Fasting blood glucose greater than or equal to 126 for diabetics. The oral glucose test or the 2-hour postprandial test, they're the same thing. That's great. If it's greater than 200, then they'll get diagnosed with diabetes mellitus. HbA1c greater than or equal to 6.5%. Random blood glucose greater than or equal to 200. So this is exactly how we diagnose type 1 as well and type 2. Okay, diagnosis, treatment of type 2 diabetes. Same thing, exact same thing, glycemic control. We need to teach them how to self-monitor their blood glucose, or they can use continuous glucose monitoring or do their HbA1c every 90 to 120 days. Now, the only difference between all of these, because remember we talked about type 1 diabetes and we talked about all of these. The difference here is oral anti-diabetics. Remember we said in type 1 we cannot treat type 1 with oral anti-diabetics because they have no insulin, right? In type 2 diabetics, they either don't have enough insulin, their cells are resistant, or their cells have a decreased sensitivity to the insulin. Even though they connect, they don't produce the same effect. That's decreased sensitivity. So oral anti-diabetic medications, what do? They increase the production of insulin. They make the pancreas more efficient. Okay, come on, let's produce more insulin. They lower resistance. They can slow the absorption of carbs that patients take. They can help lower blood glucose and increase the sensitivity of the cells so they can, work more efficiently. So a combination is used based on the client's response and goal to achieve glycemic control. First line therapy is always, most of the time, is metformin and lifestyle changes. So when a patient first gets diagnosed with type 2 diabetes, depending on how far off they are, the initial treatment is metformin and lifestyle changes, right? Diet, exercise, weight loss, all those things. Additional medications are added if the glycemic control is not met. For example, if they do not maintain the glycemic control, they might get another oral anti-diabetic, right? They'll require insulin if they're severe hyperglycemic with clinical manifestations, they're consistently high blood glucose, and they're having clinical symptoms. Their HbA1c is greater than 10%, then they're going to need insulin. They will be given insulin for sure. And they're started off normally with basal insulin, right? With the oral diabetics. What was the basal insulin? The long-acting insulin, the glargine detamere, right? The one that they take that's peakless and, it maintains a regular amount of insulin throughout the day. Okay. There's another question here. A nurse is writing orders for a patient newly diagnosed with type 2. Which initial medication orders should be anticipated? Now, this is a new patient that just got diagnosed with type 2. Diabetes mellitus. Please take a note of this and we will discuss the answer in class. Okay, so that is oral anti-diabetics. Insulin, it's the exact same as we mentioned with type 1 diabetics. So let's go back here. We talked about nutritional management. It's exactly the same with type 2 diabetics. The only difference is that, if the initial weight loss that they come in with type 2, they might come in with weight loss. We need to encourage, nutritional therapy for them. But then after that, it's extremely important for us to encourage them to maintain their weight, their BMI. Client education is very similar for type 1 and type 2. It's basically the same thing. The same thing we talked about with type 1 diabetes. And then blood glucose monitoring is also similar. The only complications are also similar for type 2 diabetics. And then the difference with type 1 and type 2, when their blood sugars get extremely high, right? We have with type 1, sorry, I'm in type 1 here, treatment, sorry. With type 1 diabetics, with type 2 diabetics, sorry, we have what we call hyperosmolar hyperglycemia non-ketotic syndrome, HHNKS. It's a serious metabolic derangement that occurs in patients with diabetes mellitus type 2 due to inadequate insulin in the body or lack of sensitivity to the insulin. Their blood glucose level goes above 600, right? And this is considered HHNKS, and they need to go to the hospital, right? This is an emergency. In type 1, we mentioned that they get DKA, diabetic ketoacidosis, right? With type 2s, they usually get HHNKS. That's another difference between type 1 and type 2 diabetics. So that is it for your lecture on type 1 and type 2 diabetes. Please go into the Genially, review it, take your time, go into it as many times as you want and review it. And please review the care plan information and the different documents I uploaded into your lecture course. And I will see you in class.